Heart failure in pregnancy final episode. How mothers survive heart failure in pregnancy, delivery, postpartum care, future pregnancies, and hope. Good morning and welcome to today's final episode of our heart failure in pregnancy series. Today we speak about a topic that carries both weight and hope: delivery, postpartum care, and future pregnancies in the setting of heart failure. Heart failure in pregnancy requires careful planning during delivery, after delivery, and before considering another pregnancy. Here is what every mother, every family, every husband, and every clinician and doctor should know. Number 1, delivery planning. Most women with heart failure can safely deliver vaginally when they are supported by the right team. Vaginal delivery remains the preferred mode of delivery, SVD. This may be spontaneous, SVD, or assisted using forceps or a vacuum device to shorten the second stage. And the epidural analgesia is recommended because controlling pain helps prevent dangerous increases in heart rate and the blood pressure. A cesarean section, C-section, is only recommended when absolutely necessary, such as when the mother has severe or unstable heart failure, severe pulmonary hypertension, dangerous arrhythmias, or when there is a standard obstetric emergency like fetal distress. So recommended mode of delivery, vaginal delivery, C-section with indications. Delivery must take place in a well-equipped hospital, a hospital with a pregnancy heart team, including cardiologist, obstetrician, anesthesiologist, and a neonatologist. Where can be ECG monitoring, oxygen, blood pressure monitoring, they must be available. And also facilities with rapid heart failure management. In terms of timing of delivery, if the mother is stable, it is recommended to deliver between 37 to 39 weeks is ideal. But if the conditions worsens, earlier delivery can be done. Postpartum care. This is a critical high-risk window. After delivery, the period within the first 6 to 12 weeks is critical, and this is the highest risk for worsening of the heart failure. There is fluid shift that peaks in the first 2 hours, so close monitoring is very important the first 3 days. The mothers will need daily vitals, fluid balance monitoring, and early follow-up at 1 or 2 weeks with continued regular reviews. We also need repeat echocardiogram, if possible, before discharge, again at 12 weeks, and again at 6 months, especially if the heart was very weak with very low ejection fraction during pregnancy. Heart failure medications must also be readjusted or restarted during the postpartum period. The following medications are safe during breastfeeding. ACE inhibitors, ARBs, which were not used in pregnancy, can now be used. Beta blockers, MRAs, diuretics at the lowest effective dose can be restarted. During breastfeeding, we still avoid ANIS, SGLT2 inhibitors, amiodarone, the DOACs, the direct oral anticoagulants, and we prefer warfarin or low molecular weight during breastfeeding. Contraception counseling is very important in postpartum period. This is to allow the heart to recover. And one of the most recommended options is long-acting reversible contraception, LAC. This is because it's long-lasting, it is effective and reversible, and does not require daily actions. Preferred options include intrauterine devices, IUDs, whether copper or the levonorgestrel IUDs. The implant, progesterone-only pills can also be used when IUDs and implants are not suitable. We avoid combined estrogen contraceptives, combined oral pills, as they raise the clotting risk and should not be used. Importantly to remember, if the EF is below 50%, pregnancy should be strongly discouraged until recovery. So what of future pregnancies and recovery? For mothers who develop peripartum cardiomyopathy, the journey after recovery determines whether another pregnancy can be considered, and we put them in 3 groups. Full recovery. When the ejection fraction goes over 50%, pregnancy may be considered, but there is still a risk of relapse with future pregnancies. It must be carefully planned by the cardiologist and obstetrician and evaluation before conception. Partial recovery, EF between 40 to 50%. The mother is at a moderate risk to high risk group. There is high chance of worsening of heart failure in the next pregnancy, and detailed counseling should be done. Preferably wait until EF goes above 50%. Class 3, persistently low EF below 40% or symptomatic heart failure. Here, pregnancy is strongly discouraged. The risks are too high, including severe life-threatening complications both to the mother and the baby. So when is it safe to try again? When can you get pregnant again after heart failure? Only after the EF has normalized, EF over 50%, and remained stable for 6 to 12 months. And before pregnancy, repeat your echo, ECG, BNP, have clearance by your cardiologist and obstetrician. What of the recovery statistics? A majority of mothers, 50 to 70%, usually recover within 6 months, and some within 2 years will recover completely. About 30% will improve only partially. However, 10 to 20% will remain with persistent or severe heart failure and need long-term follow-up. In conclusion, heart failure in pregnancy is a journey of strength and hope. Heart failure in pregnancy is serious, but it is not the end of the story. With early diagnosis, expert management, and close follow-up, many mothers stabilize. Many mothers recover fully. We have said up to 70% in 2 years. And many families go on to live long, joyful, healthy lives. And a number even get children after that. Even in PPCA, more than half of the affected mothers regain normal heart function. So to every mother facing this diagnosis, heart failure in pregnancy, hear this clearly. You are not alone. You are not powerless. There is hope. Heart failure in pregnancy is treatable. Modern treatment works. Recovery is still possible. And with the right care, with compassion, with courage, you can heal and thrive and look at the future with confidence. This has been the final episode of our heart failure in pregnancy series, saving one life at a time. Saving one heart at a time, and reminding every woman there is hope. Hope is stronger than fear. Dr. Beatrice Muthui-Mutua, saving lives one heart at a time.